So welcome to another clinical snippet video. In this video we will be discussing various forms of dyspneas and various abnormal breathing patterns. As you know, dyspnea or shortness of breath is defined as subjective, uncomfortable awareness of breathing. And especially the cardiovascular system and respiratory system are the main culprits for producing shortness of breath. And there are a lot of scales, like we know for cardiovascular disease we use NYHS grading, for respiratory we use MMRC grading. So apart from this, what I want to tell you is dyspnea is such an important clinical symptom, not only cardiovascular system or respiratory system. Virtually any system in the body can present as dyspnea, like a hepatology condition in portal hypertension with portopulmonary hypertension, or say for example hepatopulmonary syndrome can cause a various form of dyspnea which is known as platypnea. In the same time, there are other types of dyspneas like trypopnea which can occur in respiratory disease. Even your collagen vascular disorders, when they secondarily involve the lungs, they will cause dyspnea. Endocrine abnormalities like diabetic ketoacidosis, they can form a different type of breathing pattern. So every system can cause an abnormal breathing pattern or a dyspnea. So in this video we will be covering all of them, the types of dyspneas and the various types of breathing pattern along with the clinical demonstration. Thank you.
Hi, I'm Dr. Manjeet Kothari, and today we are discussing about different type of dyspneas. First, orthopnea. Orthopnea is a condition where patient is breathless on recumbent position which gets relieved on standing or sitting. Examples of orthopnea are heart failure, coronary artery disease, chronic obstructive pulmonary disease and morbid obesity. Second, platypnea. Platypnea is a condition where patient is breathless on standing which gets relieved on recumbent position. Examples of platypnea are pulmonary AV malformation, hepatopulmonary syndrome, patent foramen ovale and atrial septal defect. Third, trypopnea. Trypopnea is a condition where patient is breathless while lying on one side and not on the other side. Majority of the causes of trypopnea is left ventricular failure and pleural effusion. Fourth, bendopnea. Bendopnea is a condition where patient is breathless while bending forward. Example of bendopnea is heart failure. Thank you.
कितने दिन से सांस फूल रही है?
10-15 दिन से.
एक बार लेट जाइए ना. क्या हुआ?
नहीं fantastic.
Start. This is a case of cirrhosis with portal hypertension. Initially, the oxygen saturation of the patient is 96%. एक बार खड़े हो जाइए. क्या हो रहा है अभी?
खड़ा होने पर थोड़ी सांस फूलती है.
Now the saturation has fallen to 88%. So this is platypnea, which is showing orthodoxy.
Hello everyone, my name is Dr. Harsh. Today I will be discussing about paroxysmal nocturnal dyspnea. As the name itself suggests, it happens in paroxysms at night and it's a hallmark symptoms of heart failure. In heart failure, the fluid will be accumulated in the lower limb and it will be in the interstitium, which is gravity dependent. When a person goes to sleep, the gravity is eliminated and the fluid from the interstitium will go into the venous circulation. That will lead to increased venous return of the heart. That will lead to increase in the pulmonary congestion. Secondly, during sleep, there will be depressed respiratory centers. And thirdly, during sleep, the diaphragm will be upward. That will lead to decrease in the total lung capacity. All the three things will lead to increase in the CO2 retention and hypoxia. This will lead to increase in the activation of the respiratory center and the person will get up from the sleep with suffocation, anxiety and gasping for air. Person will walks around, roam around for 30 minutes. All during this time, all the three mechanisms will get reversed and person will feel comfortable. Again patient goes into sleep and after 2 to 3 hours the cycle will be repeated. Another important concept in paroxysmal nocturnal dyspnea is the patient presents with cough and wheezing. Due to increase in the pulmonary congestion, there will be increase in the bronchial arterial pressure that will lead to airway compression. So, increase in the airway resistance will be there, and the patient will came with the complaints of cough and wheezing. So, all the wheezing is not asthma. This is known as cardiac asthma, and here the drug of choice is diuretics.
Hello, my name is Dr. Nishant Rathod and I will be talking about pursed lip breathing. Pursed lip breathing is a kind of peculiar breathing technique which involves slowing of the inhalation and slowing of the exhalation through the tightly pressed lips, also known as pursed lips. This kind of breathing generates auto-PEEP, also known as auto-positive and expiratory pressure. It involves slowing of the exhalation to avoid the drop in intrapulmonary pressure and to prevent alveolar collapse at the end of expiration. By slowing down the exhalation, it avoids air trapping and hyperinflation. Also physiologically, we see this in athletes during endurance training and to increase the oxygenation at the end of the training. Pathological causes are emphysema and asthma. Thank you.
Hi, I'm Dr. Jayan. Today I will be talking about Kussmaul's breathing. Kussmaul breathing is rapid and deep breathing pattern which is usually seen in diabetic ketoacidosis. But this can also be seen in lactic acidosis, renal failure, salicylate and methanol poisoning. In the metabolic conditions, rise in H+ is sensed by the chemoreceptors in the brain which activates the respiratory centers causing CO2 washout by increasing the rate and depth of the respiration. Here, this is the normal tidal volume and normal respiration pattern. This is the increasing in the rate and depth of the respiration, which is termed as Kussmaul's breathing.
I am Dr. Manikanta. Now I am talking about Biot's breathing, which is also known as ataxic breathing. It is an abnormal breathing pattern characterized by regular periods of deep and shallow breathing with irregular pattern of apnea. These causes are meningitis and any damage or pressure on the respiratory centers of pons due to pontine infarct and hemorrhage, and raised intracranial pressure due to uncal herniation or tentorial herniation. Thank you.
Hi, I'm Dr. Nikhil. I will be talking about Cheyne-Stokes breathing. Cheyne-Stokes breathing is a periodic breathing which is characterized by gradual increase and decrease of tidal volume followed by a period of apnea. The causes are heart failure, intracerebral bleed, narcotic overdose and uremia.
I am Dr. Navnath. Today we will discuss about the apneustic breathing. Apneustic breathing is characterized by slow, prolonged inspiration followed by pause with sudden expiration. Now, normally apneustic center controls the inspiratory part of the respiration, and pneumotaxic center inhibits the apneustic center by acting on the dorsal respiratory group of neuron, which causes inspiratory switch off. But due to damage in brainstem injury, there is no inhibition from pneumotaxic center, which causes there is no inspiratory switch off. Therefore, there is slow and prolonged inspiration with pause with sudden expiration. Now, the causes of apneustic breathing are spontaneous strokes, head injury, hypoxic brain damage, brainstem encephalitis, organophosphate, and narcotic poisoning. Thank you.
Hello everyone, this is Dr. Avinash Parapalli. Today we will be discussing about paradoxical breathing. Generally, during a normal inspiration, the diaphragm moves downwards and abdominal outwards, creating a negative intrathoracic pressure so that the air enters the lungs. But in paradoxical breathing, during inspiration, the abdomen moves inwards, and during expiration, abdomen moves outwards. This happens in certain conditions like neuromuscular disorder conditions affecting the diaphragm, and chest wall injury or trauma, or severe obstructive airway diseases such as COPD and obstructive sleep apnea. Diagnosis is made by clinical methods, and fluoroscopy aids in the diagnosis. Immediate management is done by O2 and CPAP ventilation, and though the definite management is by treating the underlying cause.
Hello, I am Dr. Sohail, and we will be discussing about central neurogenic hyperventilation. Central neurogenic hyperventilation, it is characterized by rapid and the deep breathings, which is not driven by metabolic demands, but rather due to direct stimulation of the respiratory center in the midbrain or upper pons. Any lesion to the brainstem in the midbrain or the upper pons causes loss of inhibitory control over the respiratory center, which causes the continuous and the direct stimulation of the respiratory center, which is chemoreceptor independent. That's why we see hyperventilation and respiratory alkalosis. It can be seen in conditions like brainstem damage, especially in the pons, upper pons, head trauma, and cerebral anoxia. Thank you.
Hi, I am Dr. Rushikesh. Today we are talking about agonal breathing. Agonal breathing is an abnormal gasping breathing pattern seen in medical emergencies such as cardiac arrest and severe hypoxia. And it is seen when body is in severe crisis or near death. And in case of hypoxia, there is cerebral cortex shutdown, because of which medulla oblongata are activated, as medulla oblongata control respiratory center, because of which respiratory muscle are activated, leading to sporadic gasping breathing pattern, leading to agonal breathing. As we can see in this graph, we can see agonal breathing, in which there is sporadic breathing followed by apnea, and if it is not treated, it can lead to death.
Hi, my name is Dr. Harsh Kansagra. Today I will be discussing about obstructive sleep apnea. Obstructive sleep apnea is a sleeping disorder which will cause complete or partial obstruction of upper airway tract, which will lead to oxygen desaturation and frequent night awakening in the patient. The patient of obstructive sleep apnea will present with complaints of loud snoring, gasping sensation or choking sensation, frequent night awakenings, memory loss, fatigue, or
The causes of obstructive sleep apnea will include obesity, metabolic syndrome, micropnea, downward displacement of hyoid bone, adenoid or tonsillar hypertrophy. The patients of obstructive sleep apnea are at a high risk of developing complications like hypertension, diabetes mellitus, stroke, arrhythmias, or then treatment modalities of obstructive sleep apnea will include, for mild to moderate disease, it will include lifestyle modifications like weight loss and CPAP machine. For moderate to severe disease, it will include surgical intervention like uvulopalatopharyngoplasty. Thank you.
Good morning, I am Dr. Faizan. Today I will be speaking about stridor. Stridor is harsh, high-pitched sound that are produced when the air flows through a obstructed airway, mostly during inspiration. It can be inspiratory or expiratory. The inspiratory stridors are produced when there is flow of air through an obstructed airway and the obstruction is extrathoracic, as in larynx or upper part of trachea. In expiratory stridor, the pathology or obstruction is intrathoracic, and as it can be seen in lower tracheal obstruction. Sometimes biphasic stridor can be seen when there is a fixed obstruction during inspiration and expiration, usually seen in subglottic stenosis or a mass. The mechanism behind stridor is the generation of turbulent airflow through an obstructed airway, which produces sound that are peculiar to stridor. The causes of stridor are vocal cord paralysis, subglottic stenosis, angioedema, tumor as in larynx, and intubation-induced trauma. The stridor can be differentiated from other lung pathologies like the acute exacerbation of COPD or left ventricular failure by more activation of the upper neck muscles and the involvement of supraclavicular regions as compared to the intercostal muscles and lower ribs in the COPD or left ventricular failure. Thank you.
Hi, I am Divyansh Singh, currently now talking about death rattle. Death rattle, it is a rattling sound produced by a dying person due to inability to clear its secretion collected in the throat. It is mostly seen in terminally ill patient and it lasts up to 18 to 25 hours before death.
Hi, I am Dr. Roma. I am going to be talking about hyperventilation syndrome. It is a type of rapid and deep breathing which is triggered by emotional factors such as anxiety or emotional stress and can also be caused by hypoxia. Hyperventilation leads to increase in the CO2 washout, causing respiratory alkalosis, and in a predominantly alkaline medium, the binding of calcium to albumin increases, which reduces the free or active form of calcium, which is the ionic calcium, and leads to hypocalcemia. It causes significant signs, symptoms, and clinical features, which are perioral tingling, carpopedal spasm, laryngeal spasm, and chest pain. Then the patient can be treated by giving him reassurance, asking the patient to breathe through one nostril and closing the mouth, applying upward pressure on the chest to encourage more diaphragmatic breathing. The signs of hypocalcemia can be elicited through number 1, Schwastek sign, that is tapping the facial nerve in front of the ear to elicit the Schwastek sign. A positive Schwastek sign will cause twitching of the facial muscles. Second, we can elicit hypocalcemia also through Trosu sign, which is the carpopedal spasm, which occurs when the blood pressure cuff is elevated by 20 to 30 mmHg, which is more than the systolic blood pressure, and it causes the carpopedal spasm. Earlier, it was thought that breathing into a paper bag will cause alleviation of the symptoms, but this method is obsolete because it can result in worsening of the hypoxia if hypoxia is the cause of hyperventilation. Thank you.
बैठो क्या हो गया
ब्रीदिंग इशू हो रहा है
क्या हुआ कुछ हुआ
एग्जाम में पढ़ाई नहीं होगा
ठीक है ओके लंबी लंबी सांस लो, हो जाएगा हो जाएगा। अभी एक नाक बंद करो, मुंह बंद करो, लंबी लंबी सांस लो, हो जाएगा। लंबी सांस लो, पेट से सांस लो, लो, पेट से सांस लो,